Dembowski.
Thank you so much. What a great day you guys have planned, and I am thrilled that you've chosen to attend this as the first talk. I think when we think of aging, we think of so many different topics, and we're not always planning for this topic unless you've already had an experience of it. And I'll give you an idea of why every one of us needs to think about our heart health as we age. So I like for this to be kind of not a didactic, meaning I don't want to lecture. If you have questions, if you have thoughts, let's just kind of have this as a dialogue. So how many know whether this is true or false? Is heart disease the #1 cause of death for men and women, for both men and women in the United States? How many think it's true? Great, all the experts came to this room. I love it. So obviously it is. It is the leading cause of death for both men and women combined. Usually when I give a talk to a population that's older, they correctly identify this as the leading cause of death. Obviously, when you talk to children or adolescents, they have no idea that this is their biggest risk down the line, because it's not in their age group, but down the line it will be. And certainly in women who are in their 40s and 50s, they often still say breast cancer, because those deaths are usually traumatic for people and you die young. And so I think that breast cancer advocacy has been so powerful that oftentimes that is the identifying lifelong risk. It is true that when you're 40, 50, it's not heart disease that's getting the women, but down their life, in their lifespan, you have to plan for your heart health, because this will be your leading cause of death if you do not. And I put COVID over here. Of course, these statistics are old, but I put COVID because some people lately had been identifying COVID in those years, but that obviously was not the case as well. The other thing is, what does aging do to our heart? Well, we know from all of our data science, how do we know who's at risk for heart disease, who's not, is that we've studied this for decades. Hundreds of thousands of people have been put into databases, and who gets the heart disease? Why do we get heart disease? This is something that's been kind of studied for the last 100 years. This is not novel, okay? And when we do these kind of studies, age is almost the strongest predictor always of cardiovascular disease for both stroke as well as heart attack. Is it that age is bad for our hearts? Well, there's a lot of things that is not studied yet well in this field. We know that all of our cells go through a process called senescence. Have you heard that terminology, senescence? Senescence just means that your cells start to function differently the longer we go on, almost like we have a timeline. And that's in every living organism. That's not unique to humans. That's in every living organism. There is a timeline for cellular processes. And that's the same for your heart. There are a lot of different functionings of your cells as you age. And fortunately, because we have conquered or understood so much of heart disease at a younger age, we are now focusing on a lot of these mechanisms of the aging heart. Here's another thing to ponder when you think about that heart disease is the leading cause of death and age predisposes to heart disease. This is kind of written in a way that I think you'll answer it correctly, but older adults greater than 65 years will outnumber children in the United States by 2035. This is the truth. Through the trends of how it looks, the linear trends of how much less children we are having, to how much we are aging and aging well and living longer, we feel that by 2035 we'll reverse. So we will have more seniors greater than 65 than we will children. When you think about all that, you think about the fact that, okay, we're going to have more heart disease. Heart disease will be more prevalent. And because we're having solutions for heart disease, hopefully it won't result in our death, but rather it will result in something that we will have to manage, we will have to plan for, we will have to live with. And so is born now a field called geriatric cardiology. Some people like having subspecialties, some people don't. A lot of cardiologists treat people who are in the geriatric senior population. They're not, most of us know how to treat people that are senior, but why form something like geriatric cardiology is mostly for research purposes, right? To attract funding, to study these aging mechanisms, to really start to learn how can we effectively manage, or maybe there'll be some special treatments that we can do to counter the effects of the aging heart. So geriatric cardiology, you'll probably hear that term more often. Really in the community, there's not many of us. I work for Endeavor Health right here in the local community. We don't have a geriatric cardiology. All of us see people of all ages. But certainly in the university settings, this will become more and more popular. And these people are probably at this point researching it, not necessarily doing anything clinically different. The other thing, though, is when you see a person who is aging, when you think about care of the older heart, you have to combine all sorts of different pieces. So doctors live in this red world. Let me see what this is. Where's my pointer part of this? This, right? We live here. We like to talk about the medicine aspects, what medications I can do, what procedures I can do. We like to understand things medically. But when you treat the elder population, much like you would treat pediatric population, you have to take into consideration other factors in order to understand not only the goals of care, what the thought process is for that patient, that family, but also what the success of your care will be. Because you have to remember that everything we've studied about cardiology, about your heart, is usually not studied in patients of advanced age. I would say that most of our trials for why things are successful, not successful, 90-year-olds are not included, 80-year-olds are very seldom included, and even 70-year-olds sometimes are not included in these trials. There's a cutoff. You can understand why. As we age, there's more chance that that intervention, that medication's not going to be as effective. And so when we're studying it, oftentimes we put cutoffs and say, okay, we're not going to study somebody greater than 65 for this medication. And then what happens after the trial is done and is shown to be successful, we extrapolate, meaning we say, okay, it turned out to be very successful for a 50-year-old. Is there a reason it shouldn't be at 80? And then we kind of use that method too. But remember that a lot of the things that you're recommended to do in those ages wasn't really studied for you. And that's because the combination of these things seems to be more influential into the treatments. So for example, cognition, depression, anxiety, which is much more prevalent to be dysfunctional at older age. So people have more issues with cognition, with thinking, dementia. That will impact the success of our treatments. Physical functioning, we'll talk a little bit about frailty. So it's a lot different to have someone who's 90 and still walking every day versus 90 who's barely moving, right? So we have to take this into consideration. Social environment. This is very key to your heart health. And now, in fact, in any of your health, it's very key. If you have a family that's taking care of you, if you're living with people and you're a part of kind of a society that's taking care of you, your outcome will be better. We'll talk about how that comes into play with specific situations. So when you're thinking of geriatric cardiology, most of the physicians are thinking in addition to their medical knowledge about these three components. And then together with the patient and family, we come up with solutions. I'm going to go through cases, and that's how I like to present kind of a few topics on cardiac issues for patients, because these are cases of mine that help you understand where we are in cardiology today and kind of what we should be thinking about, how we can be focusing on different aspects of geriatric care. So here's a case. I had a 96-year-old male who's admitted to the hospital with shortness of breath. He is found to have pulmonary edema. Pulmonary edema means that fluid went into his lungs, and he can't breathe because there's fluid in his lungs. He improved with Lasix. Lasix is a diuretic, so we gave him IV Lasix. It cleared the edema. He's now breathing well. But now we have to ask, well, why did that happen, right? Because if we just did this and let him go, but didn't address why it happened to him, chances are it's going to happen again. So now we look at why is this happening. And the first thing we like to do when you have pulmonary edema is look at your heart function. And we look at your heart function with something called an echocardiogram, which is an ultrasound. An ultrasound of your heart tells us how well your heart squeezes, how well your heart relaxes, and it also shows us your valves. So we have 4 valves in our heart. It shows us how well they're functioning. Are they leaking Are they too tight? Are they not opening well? And so this man ended up having severe aortic stenosis. Aortic valve is the last valve of your heart. It's the valve that all the blood exits into the body through that valve. And this valve, as we age, some of us, probably 20% even, as much as 20% of us, will have this valve become dysfunctional. It likes to get fibrotic, which means thicker, calcified, calcium deposits on there, and for some of us, that will affect its functioning. Most likely, if that process starts, if that valve ages like that, it will stop opening well. So it will become more and more resistant to opening, and eventually severely resistant to opening, to the point of having severe aortic stenosis. When you have severe aortic stenosis, your life expectancy starts to be limited once you have symptoms. So here's a patient, this is a hypothetical patient, not this patient of mine, but hypothetical. You're doing okay with that severe aortic stenosis, your body's tolerating it until you get symptoms. Once you get symptoms from that valve, your life expectancy dramatically decreases. We almost have a prescription for how many years you have left once you have symptoms. If you get symptoms of chest pain, it's about a 5-year life expectancy. If you're fainting because of the valve, it's about a 3-year life expectancy. And if you have heart failure, we'll talk about that terminology lately, but having fluid in your lungs is a sign of heart failure. So that's what my patient had. This 96-year-old has now heart failure because of his severe aortic stenosis. His life expectancy is on average 2 years, usually even less.
Which of the symptoms is most prevalent? I mean, do you get the first symptom of fluid in your lungs?
Can be anything. So this cutoff is any symptom. The most likely symptom for people that are paying attention to this valve is having just a decreased exercise capacity. Usually if we're catching it early, and we catch it early because sometimes you have an ultrasound and for other reasons and you're in the moderate category, and then we watch you, and what we see is that the most likely symptom that you can get first is just suddenly not being able to do as much. Now you can imagine there's a lot of reasons you can't do as much, right? So that's why we work very closely with these types of patients to appropriately monitor you, and we have ways to test to see if your decreased exercise ability is from the valve versus not. So there are tests that we can do to kind of assess, is it the valve that's the problem or something else? So now we've got an individual who we know his life expectancy is affected by his situation. So now we got to come up with, what are we going to do to help him? And some of you might have heard of people having this type of problem. Some of you have not. But whenever we face a patient, we always think, well, we can do nothing. He's 96, we can do nothing. Can we treat medically? We always try to do the least invasive thing, obviously, and the answer is no. In this situation, there's no cocktail of medications that's going to affect his mortality. His mortality is affected by that valve, and we can't do anything with our medications today. Who knows what the future holds, right? We can't do anything with our medications to change that valve. That valve will be blocked for him with no matter what medication cocktail we put him on. So the only standard of care, if we want to do something, is to replace that valve, to give him a new valve. Historically, we used to replace the valve surgically. That's this, what we call SAVR, replace the valve surgically. Nowadays, luckily, we have another technique that we can replace your valve without cutting, without getting into because remember, surgically is a big surgery. When we do heart surgery, we have to go through your bone here. That's a big deal, especially in a 96-year-old who's going to heal differently, who's going to be maybe not moving as well for a long period of time. So when they have to recover surgically, that's going to impact him. So nowadays we have this thing called a transcatheter approach. The transcatheter approach is that we take through an artery in your groin, we're able to take wires and tubes up towards the heart to that space right where that valve is. The valve is then over a wire delivered. It looks like this, but when it's over that wire, it's all scrunched up. And then we inflate a balloon like this. Right when it's positioned appropriately, we inflate the balloon. And then when we deflate the balloon, the valve stays there, and then we take out the balloon and the wires. Amazing, right? What technology allows us to do. So this procedure is something that we can now think about. So I would say that a 96-year-old 10 years ago, if we were thinking about surgery, replacing his situation, we would probably say, no, we are not gonna go for surgery for you. But nowadays, because we have this, we're pushing the envelope. We're saying maybe this is now the right thing to do for something like this, somebody like this. Yes, so who said that? Smart, yes, absolutely. Stents are the same type of technology. First, stents were created, and stents are created for coronary disease, for blockages in your heart arteries. And then through that, people thought, well, why not the valve, right? And then that's how this was developed. So same exact technology.
The recovery.
The recovery is much, much faster. And here's the slide about, is it just as simple as that? So if we have this technology and the recovery is much simpler, recovery is usually a day or two, because we have nothing other than the puncture site where we went into your artery in your groin. We don't have any of the healing that it takes for surgery. And the valve itself, if it's successfully placed in the right, hands, and you're fine. You're essentially better because you now have that new valve.
Would something like this just happen to like the elderly? I mean, would somebody younger get something like this?
Great question. So let's first talk about this patient, and then we'll circle back about that, about what should we do with younger patients. So is this safe, this TAVR procedure, in elderly patients, in a nonagenarian, which is somebody who's obviously 90, right? So we do know that more complications will happen if you're 90 versus 70 versus 60 with this procedure. And I would say across the board, that's the case with almost everything we do in medicine. When we touch somebody who's of very elderly age, we do have more complications. So how do we discuss that with a patient? Well, what we have uncovered, it's not your age. Like I said, it's that frailty. So the answer to this question is we have to consider the patient's frailty. Frailty is complicated. Frailty is how well you're functioning. And we have to, because we like to measure things. We don't like to make subjective assessments, right? We don't want to say, oh, you look frail, you don't look frail, you look kind of frail, because that's not the right way to approach things. So we measure frailty. Frailty is the idea that your nutritional status, if you're malnourished, your sarcopenia. Sarcopenia is your muscle mass. So as you age, some of us are going to start losing our muscle mass, get weaker and weaker. That contributes to our frailty. And people who have a high frailty index do worse with this procedure. And this is kind of a graphical representation that obviously you could have a 90-year-old who's in the left side, who's got good muscle mass, not nutritionally deplete, still very ambulatory. That will do better with that TAVR procedure than someone who's in a wheelchair bound, lose muscle mass, maybe doesn't walk. There's a lot of tool sets. This is the one I use to assess frailty. And I use it because I like the 4 components. So one is how well you can rise. So how good are your big muscle groups, right? Because you're rising from a chair, you got to do your buttock and your thigh muscles, and those are large muscle groups. It's okay if you've got arthritis and you can't manipulate your hand. That's not part of frailty so much, but the large muscle groups certainly are. So can you do chair rises? Cognitive ability is definitely in the frailty. Do you have cognitive impairment versus not? Are you anemic? Anemia, your hemoglobin, is a sign often of chronic illness. So most people who are elderly who have anemia, it's because they have other chronic diseases that are contributing. And then serum albumin is a measure of your nutritional status, because that's the protein in your blood. So this is one that I like to use. And then what do I do with that information? Well, I don't refuse treatment, because this is still possible to do. But then it's a discussion with patient and family. It's discussion saying, well, you might be more high risk for this procedure, even though it's not as invasive as a surgery. You might be high risk. What are your thoughts about it? It's a lot of discussion in this age group, right, with your physician. A lot of people who are this age have an idea of what they want their life to look like. A lot of them do not want to go on for more procedures. And then knowing that they might be more high risk, they might choose, okay, I don't want to do anything. Maybe knowing that they're not on the frailty at all, that they got a score of 0, maybe they were hesitant to do any procedures at that age, but then we're going to say, wow, we have this procedure that can really help you, and you're going to do well with this procedure. So maybe that sways, kind of pushes their opinion to, let's go for it, let's try it. Okay, so we discuss then. We do the frailty index in my clinic. We think about whether it's the right thing, and then we go on if we feel that it's something viable. We're pushing the envelope, now to answer your question, we're pushing the envelope of these less invasive technology with all patients now. Obviously they were developed for that situation of that 90-year-old is not going to do well with surgery. We knew that for decades. So the technology was developed to help that situation. But now because of the success of that procedure, we are actually doing younger and younger patients, and I wouldn't be surprised if surgical valve replacement for aorta, the aortic valve, won't be the standard of care. It's not yet. We still offer surgery for certain patients for a lot of complicated reason, but absolutely now we're starting to think, even for the low-risk patient, the patient that's young and could do well with surgery, we are starting to always think about whether to just do TAVR. Okay, go ahead.
I had the classic widow, whatever, and I didn't know, but I was having chest pains, and then I got clammy, and I'm like, this isn't good. So I lay down for about 10 minutes, then I did a Pilates class, then I lay down some more, and then the people at Pilates go, you need to go to ICU. And I didn't. I went to urgent care, and the doctor came out with the results of the heart thing. And she says, I got some bad news. You need to go to the ICU immediately. So eventually I got there. It took some time anyway, and I got there, and they took me immediately, so I knew there obviously was something wrong. And they put me in the thing, and they hooked me up to all kinds of crap. And then I met the doctor. He didn't do it immediately, so I knew I wasn't horrible. I don't know that.
Well, let's circle back to that, because this is not the Widowmaker, so we'll talk about the Widowmaker later. This is the valve, so not the story, but we'll circle back to your story when we're talking about coronary disease, blockages in the heart arteries.
I was getting there.
Okay.
He said, when he showed up the next morning,
yeah.
He said, we can either do it in your groin or in
yes, that's different. You're talking about something different. I promise you we'll get to your coronary, because coronary disease is definitely part of this. That's okay. So let's finish up with the valves. So the answer to your question is yes, we are offering it to younger and more low-risk patients. But I just wanted to let you know how amazing time frame we have medicine, the pace of medicine and new discoveries is getting so fast, it's so exciting, right? New things all the time. We talked about this valve, the aortic valve, but we are now offering these types of procedures for the mitral valve, which is a different type of valvular issue, for both leaky valves as well as tight valves. And we are even offering it in its infancy in researches for the tricuspid valve. So all these things that used to have valvular surgery, we're pushing to these transcatheter procedures, which opens up the door for you to get it when you're older, right? Because surgery at an older age, all that healing is definitely problematic. So very exciting, lots of different technologies being opened. Okay, transitioning, getting out of the valve world. No more valves, we're not gonna talk about valves again. Here's another case, 82-year-old female admitted to the hospital with palpitations and shortness of breath. And she is found to have atrial fibrillation. How many have heard the term atrial fibrillation? Yeah, usually in a crowd like this we hear tons, right? Because it's very, very common to have atrial fibrillation. She has a history of unsteady gait and has fallen twice in the past and uses a walker. So does anybody know the harm of atrial fibrillation? Why do we worry about atrial fibrillation? First, I'll tell you what it is, for those that don't know it. Atrial fibrillation is when your heart rhythm does not respect its normal order. Normally there's a very orderly way of you fire here the electricity, you move here, you fire here, you move here, and then you spread the electricity nicely. Everything is like a march, which means that it's even. In atrial fibrillation, this chamber decides to fire at will, usually around these things called pulmonary veins. There's a lot of electrical impulses that are firing at will. It's erratic, it's irregular, and it likes to go fast. So your EKG gets distorted, you have atrial fibrillation. Most people feel it as palpitations, some people feel it as shortness of breath, some people feel chest pain, some people don't feel it at all. But does anybody know what the big worry about atrial fibrillation is? You don't die from this. Blood clots, excellent. So when you have erratic electricity, that chamber is not pumping normally. It's not squeezing all of it, but it's squeezing random parts. When that happens, blood kind of gets stagnant, is not flowing forward. You can form a clot. If that clot forms and decides to break off randomly one day, it travels out of your heart to your brain, you get a stroke. Not everybody with atrial fibrillation gets a stroke. Anywhere from 2% to 10% of patients can get a stroke per year. And we really worry about that, and that's the biggest discussion in clinic for what to do about that stroke risk. What happens to you when you have stroke risk in atrial fibrillation? We give you a blood thinner. The blood thinner prevents the strokes. This woman is high risk for a blood thinner. She has an unsteady gait, she's falling. Blood thinners don't make you bleed, but you bleed more. If you fall, if you injure yourself, you will bleed more. So it's a big deal to put an 82-year-old who's using a walker and falling on a blood thinner. This is when we have to take into consideration all sorts of factors here. So we're talking about now this part, which is reduction of your stroke risk in atrial fibrillation. We need to see, should we put her on a blood thinner, or is her bleeding risk so high that maybe she's going to be too high risk for that blood thinner? In addition, we're also going to think about, well, what can we do to prevent the atrial fibrillation? But regardless of whether we prevent it, she's still going to need a blood thinner. And that's also problematic as you get older, because all of the medications that we use, people usually are on tons of other medications. So we have to think about all these interactions. So the care of atrial fibrillation when you're older is more complicated. So what should we do to decrease her risk of stroke? Again, always have the option of do nothing, just let that stroke risk be there and tell her, okay, it's not 100% of people that get the stroke, but it's pretty high. Or we say, let's start a blood thinner. Or nowadays, we have a new device, something that can avoid your blood thinner and still protect you from stroke. I want to stress the opinion that the do nothing is not the right strategy. A lot of people historically, physicians and patients after a discussion, would do nothing. And the reason they were saying is that bleed risk for her is so high, let's not harm her, let's not put her on the blood thinner. The reason that that's not good is that as we age, that risk of stroke gets higher and higher. So we're taking someone who's got a very high stroke risk and not doing anything. That doesn't make any sense to do that. So we need to appropriately prescribe the blood thinners or do this procedure for you. And go ahead.
Do they not, my dad had that, they don't put a pacemaker in, that doesn't help?
No, pacemakers don't do anything for the stroke risk, nor do they prevent the AFib. Most patients that get the pacemaker, it's because medications are needed to treat the AFib, to prevent it or slow it down. And that results in too low of a heart rate, and so they put the pacemaker in. That's a specific situation. But pacemakers do not do anything for AFib, okay? This device is now the stroke reduction device. So outside of thinning your blood with a blood thinner, we can place something called an occlusion device into your left atrial appendage, which is where usually the clots form. And that is just like a little mesh that prevents the clots from getting out. Very effective.
Is that like the Watchman?
It's called the Watchman. Very good. That's only, I'm not going to use any brand names because there's other companies that do this. But yes. Here in the local area, I would say Watchman is probably the most used of these devices. Okay? Again, something that has to be discussed, especially if anyone's telling you or your loved ones or your friends, no blood thinner, just take your chances with stroke. There's no reason to do that. If you're high risk for a blood thinner, we consider this. How many of you guys have a wearable cardiac monitor? Yeah, more and more. This is like so much more prevalent. So I certainly do not, what do the wearable cardiac monitors do? Well, they monitor your heart rate, they tell you if you're an AFib. That's the number one use for them in a population. Why is that important? Is some people do not feel the AFib, so they might have that stroke risk and not know about it. So it's a good idea to detect AFib, especially if you have risk factors for AFib. This makes sense. I'm hopeful that one day this will be covered by our insurances, something like this. It's not. It's expensive. As you see here on the bottom is the price of these things. They're very expensive. And then when you look at how well they are in detecting AFib versus how well do they do by not telling you that you have AFib when you don't, the magnitude of that benefit is not that great. So when we do things in medicine, like when we do tests for you, our sensitivities and specificities, which are fancy terms for detecting the disease versus not being wrong, are usually in the magnitude of 90%, right? So we don't send you for a test that has like here's the Fitbit, a 66% chance of finding the AFib. We would never send you for a test like that. 66% is lousy, right? Or a 79% of being wrong. So, I shouldn't say that, 79% of being right, meaning saying that you have AFib and you actually have it. We would want these to be in the 90 percentile for all our tests that we give you, the ones that are prescribed by doctors. So these are not good enough for us to say, yes, please go and buy yourself a $250 item or $450 item. We don't do that. But I have to say more and more of you have it, wear it. And if you sense it, a lot of my patients are sending me the strip and just saying, this is what my Fitbit told me, is this correct? And I have diagnosed new AFib based on these in a patient that just all of a sudden sent me something, and yes, it is. And I had no idea that they had it. Go ahead.
If you just take your heart rate, can that just
Yes,
tell you?
if you're good at taking your pulse, which honestly is a skill in of itself, I can't tell you, 50% of medical students have a hard time with this. So I can't also state for all of you to start doing that, but if you're good at sensing your pulse and you're good at sensing it being regular, then regular is normal. If it's not regular, it might be AFib. It might be other things, but it might be AFib. So yes, if you want to sense your pulse every once in a while, or if you check your blood pressure, the blood pressure monitors usually have like a little heart indicator, and sometimes they're able to say that it's irregular, and they mention it to you on those automated cuffs.
I'll tell you, the best gift I got myself was an Apple Watch. And both times I had COVID, I had it a month ago. I was just feeling like crap all day because I take care of my mom. I lost my dad 2 months ago. He had AFib and all that. And I was feeling really bad. And I looked at my watch, and it was giving me a alert. I had 130 heart rate, and I didn't even really
Realize it.
It's amazing. Both times I have.
Yeah, so some people enjoy that. I can tell you the flip side to that is some people get stressed by it.
Yeah.
And then it doesn't make any sense, right? So if you're gonna worry and constantly worry about it, some patients I've had to say, please stop your Apple Watch, take it off for the night, go to sleep.
And then I would check.
Yeah, I mean that's some people, that it helps them. So if you're gonna do it, that's fine. Know that it's not 100%, okay? Know that it's not 100% either accurate or gonna help you in your situation. All right, next, yes.
Yeah, I was recently diagnosed with AFib, and my doctor only mentioned doing the test where it gets your heart back into rhythm.
Yeah, so we didn't touch on that. So I talked about the stroke risk because I think that has the nuances for older age. There's a lot we can have a whole hour on just AFib. We can have actually a whole conference on AFib. There's so many nuances to what to do when you're in AFib. Should you get rid of it? Should you just leave it alone? Should you burn it away? Should you get a cardioversion, a zapping? There's so much to that. So obviously once you have it, you need a cardiologist to do a one-on-one discussion with your specific case.
Okay, but my question is with the netting that you mentioned.
Yes.
What's the recovery time?
That's another one, just like the TAVR procedure. These procedures are in and out, literally observation sometimes, and sometimes go home that same day. Okay, switching the gear from atrial fibrillation, now to another topic. 78-year-old female with many, many medical problems, which is common as we age, right? Diabetes, kidney disease, high blood pressure, cholesterol issues, thyroid issues, arthritis. And she's coming into the hospital with shortness of breath, weight gain, and swelling. She is found to have that word congestive heart failure, which we're going to talk about what that means. She takes 9 prescription medications to manage all of her conditions, lives alone, children are nearby, but lives completely alone, so is trying to be independent and is completely doing everything on her own. Very common story for this patient population, right? As we age, a lot of people are like this. It's a lot to handle. When you're 78, living alone by yourself, now you're going to have this diagnosis of heart failure. So what is heart failure? There's 2 types of heart failures. I wish we could get rid of that word, but that word will stay for us, and it's a scary word, right? It makes you sound like you need, you're going to die. Unfortunately, it is a word that simply means that your pump is dysfunctional. It can be dysfunctional in 2 ways. The heart is a pump, right? So it's just supposed to pump all your blood forward. It can be dysfunctional in 2 ways. One of the ways is systolic failure, meaning it doesn't squeeze well. So it's not squeezing, the muscle is weak. But the other, more prevalent, especially in women, way that you can get heart failure is that it doesn't relax well. Your heart is more stiff, so it can't accept the blood. If you can't accept the blood, there's not much to pump out, right? Because you accepted less blood. So that's another way of getting heart failure. When you get heart failure, you get those symptoms. You start to retain water. Why? If the pump is not pumping forward, you get backfill. You get backfill into your legs, into your belly, into your lungs. You might not breathe well. You also have trouble with supplying blood flow to all your organs. You might have kidney issues. You might have stamina issues that basically you can't really do much activity because it's not effective at supplying the blood flow to your muscles. This is a busy slide, don't worry about it, just to highlight the fact that women get more of that diastolic or normal squeeze function but stiffer heart. Men, that's different. So systolic and diastolic blood pressures are different from this concept of your pump is systole, diastole. My kids run around, they go systole, diastole, systole, diastole. They've already learned those words. But it is, when you squeeze, you get systole. When you relax, you get diastole. And then the blood pressure that you sense is those different components. That's why you know those words. But that's the function of it is systolic function, diastolic function.
What I'm reading is which?
Top is systole, bottom is diastole. Okay, so we classify heart failure. And unfortunately, they have come up, I was very against this, they've come up with stage A heart failure. Stage D heart failure are what you read. So when you go online and you start reading the word heart failure, you're going to get a lot of stories here, which are the bad stories. These are the people that really need our help. Majority of people are here, B or C. Stage A heart failure is all the people who are at risk for heart failure. So if you have any condition that puts you at risk, if you have high blood pressure, you're stage A heart failure nowadays. It's not a good terminology, but it gives your doctor a good idea about how aggressive to be with things to prevent having heart failure long term. We also classify it in different subclasses of how well you function, 1, 2, 3, 4. Basically, majority of the literature, if you just Google the term, you're going to Google things that are for this person and this person, which is the worst of it all. That's why most of my patients that hear the word heart failure, I say stop reading on the internet, please. But having said that, this woman now who's 78 with all these medications, 9 medications, is now going to need a lot of treatment to prevent the situation from coming over and over again. It's a big deal when you start to have this, because now you're going to need medications to help you. You're also going to need lifestyle changes. There's a whole program of how to manage you effectively. And it often involves a lot of self-checking, a lot of changes, maybe going up and down on medications. And that's why I bring up the point of when you're 40, 50, you can kind of go along with this. When you're 70, 80, 90 and you have this diagnosis, and especially if you live alone, it's tough. It's tough to manage this diagnosis. And that's where we come into all these parts, right? Imagine somebody who's doing all that self-care and can't mobilize, right? Can't make it to the bathroom in time because we put her on a diuretic. Or maybe cognitive, she's getting along okay in terms of shopping for herself, cleaning, but now when we give her a cocktail of medications to take this one at this hour, this one at this hour, this one at this hour, it gets overwhelming. And then the lack of the direct person in her life every day, the whole thing can unravel and just be really hard to manage. So the solution often is a multi-center approach. It's not just having a patient and a doctor, but multiple people involved in the care to help. Cardiac rehab helps, things like pharmaceutical help, dietary help. And our solution at Endeavor, and many hospitals, it's not unique to us, but is to form heart failure clinics. So often this type of patient is enrolled in a special clinic so that they have a whole team of people. This is one of our physicians. You probably know which one is the nurse practitioner, but yeah, so our chief nurse practitioner who does this. We have a whole team of people to coordinate all this care among all those different subspecialties. So really you kind of, if you have that diagnosis of heart failure, if your loved one or friend, make sure that they are in some type of heart failure clinic. It doesn't have to be ours. Many of the hospitals locally are doing this type of work, but very critical. Okay, so now I gave you 3 scenarios: heart disease, heart disease, heart disease. And you're thinking, oh my gosh, I am 75. My age you just told me is a risk factor for heart disease. I can do nothing now to decrease my risk. Is that true or false? Absolutely false, right? American Heart has shown us over and over again that yes, you might have a risk factor that you can't change, like age, but if you have less risk factors, you will do better. So that means control the things that you can control, and you absolutely will do better. If you have all risk factors optimized, that's obviously great, but if you don't, you are still doing better than the people that are doing a lot of things that are contributing to their heart health. So what are they? American Heart is now have the Life's Essential 8. Every year we get a little bit more and more in terms of the risk factors. So we always add one as we get more understanding of what contributes to your heart health. So 1, try to be as active as you can. This is where that frailty comes into play. People that are in a wheelchair can't be as active, but you know what they can do? Sit and be fit classes, right? There's a lot of things you can do in your wheelchair to stay active. So whatever functionality you have, try to match that with appropriate activity. If you're not sure, that's where a rehab center can come into play. That's where physical therapy can do an evaluation to help you come up with how you should be active. Eating better. Even at age greater than 75, you still benefit from dietary changes. Doctors sometimes will say, well, you've eaten that way your whole life, just go ahead. I don't agree with that. I think even if you make tweaks after the age of 75, you will do better than not making those tweaks. One of the things I like to do is broad strokes. I don't like dietary plans, especially not at elderly age, because I feel like no one's going to follow them. But I basically advise 50% of your intake should be fruits and vegetables. Every time you have a plate in front of you, 50% should be fruits and vegetables. 25% should be starches that are complex. 25% should be that protein based. I also like intermittent fasting if you're non-diabetic. Diabetics, don't listen, because now you need maybe more caloric intake. But if you're not, shut your time off for eating. You only really should be eating for a small period of time, right? We shouldn't be eating like we do because food is plentiful. We eat throughout the gamut of the day. Narrow that window of eating and then drink nothing but water for the rest of the time. Well, this is one plan that I propose, and this eating window should be as far away from sleep as you can. So I usually talk to my patients, when do you go to sleep? And then I try to push back their eating as far away from their sleep as they can, but make sure that they get 8 hours in. I also don't want to limit calories too much. So this doesn't have to be a certain time.
So you start at 8 in the morning, you want them at 4 in the afternoon?
That's typically what this would entail, if you can do it. A lot of this is discussion with your physician. They have to know who you are, what other diseases you have, what other medications you have. Like I said, do not do this if you're diabetic. Okay, sodium. This is one where everybody above the age of 75 should pay attention to. You really should not be overdoing sodium. You don't have to eliminate it completely. In fact, that would be dangerous. But know that our American diet and what is available to us when we eat out is extremely high in sodium. It's very common for Americans to be overdoing salt by 2-3-fold because we put it into most of our foods. The high risk ones are obviously pizzas. Remember, breads and rolls are usually high in salt. Sandwiches because of deli, soups, canned goods, and obviously takeout. A lot of fast food is very high in salt. Manage your weight. This is a tricky one when you're older. because we don't want you to be losing weight tremendously. That could be a sign of that sarcopenia, frailty. We don't want you to get malnourished. So this is another one where we have to talk with a physician about what are your weight goals. Sleep, so critical to sleep well. If you're not sleeping well, we often send you to sleep centers nowadays. We look for sleep apnea. Very important to have adequate sleep to restore yourself. These are ones that I can do for you, help you with your, or any cardiologist, any physician, controlling your cholesterol. Sometimes that means medication, sometimes not. In advanced age, the benefit of statin is not necessarily known. So starting a statin, which are used for cholesterols, might not be the right choice. This is a big discussion with your physicians. How are we on time? Am I over already? Oh, okay, I have a little bit of time. So I will tell you that here's cholesterol. This is a true life situation that I had. 2 people, age 76, never seen any medications. Naturalists, they don't want to be on any medications. They come to me with 2 cholesterol profiles. You probably are familiar with LDL, which is the bad cholesterol. HDL is good. Triglycerides, which are like the sugar of your cholesterol. This LDL is very high. This LDL is high. This is a 76-year-old male, 76-year-old woman. Which of these should start statins? Well, a lot of physicians say it's high, just start it. That's not the approach that I take. I feel very much, is it too high for you? Because sometimes you can do something called a calcium score, which tells me how much plaque you have. And at the age of 76, it's pretty telling. If this comes out to be a score of 0, meaning you have no plaque, hard for me to argue that you should now treat that cholesterol that you've never treated. And so that was the situation in this. Despite this woman having a double high cholesterol, she had no plaque. And her husband, who has that moderate to high cholesterol, but not extremely high, he had plaque. So he definitely is in the benefit window of statin, and she's under question. And so at that point, if she had told me I want to do statin, I would feel much easier because I believe in statins. Statins help you. Statins will decrease your chance of heart attack and stroke. But she didn't want a statin. Her calcium score is 0. She's never treated it. I shouldn't say allowed. After risk discussion, we came up with the fact that, okay, we're not going to do it and we're just going to monitor you.
How would you test for statin if they have a lot of, or not for
So this is that test. So I breezed through it just because of interest of time. Calcium score is a low energy CAT scan. So you go into, it is a CAT scan, it is radiation. You can't do it every year, but it's so much less energy than, it's less even than a mammogram. So it's not a lot of radiation. You get scanned and then we see how much calcium comes up. As you don't see this in this bad image, but like here is calcium. It's the same as the bone in terms of whiteness, and those are the arteries, and they should not be white. They should be more gray on our scans, meaning flow. Yeah, I wouldn't. So a lot of stand-up clinics do it. You can go in and right now, every single person right now can walk in and get a calcium score. You don't even need to get it prescribed because they have these things called Heart Check America where they just drive around and do it. I'm not a fan of that because again, it's radiation. You should ask your physician if this will add to your care. If you are somebody that already has heart disease, this is not going to help us because we already know that you have plaque. So in the case of the widowmaker here, which she ended up with something, we're not going to do this test for her because we already know that she had plaque. You need to know if this is something that makes sense. So I met those patients. They had high cholesterol. They didn't want to start anything. I proposed to them, well, let's see how much plaque you have. That makes sense. And then we made a decision based upon more information.
What about using prophylactically? I have been prescribed recently. My LDL was okay for a normal person. I'm a person with normal issues. But then I had TIA in my, because something was in my eye.
Yeah, perfect. Great question. So the question here is the number important for your cholesterol or is it who you are? And the answer is 100% it's who you are. Not only does that make us determine do you need the statin, but how intense to be with our statin. Because someone who had a TIA, which is a pre-stroke, obviously we have to beat that down, that cholesterol, to as little particles as we can because less particles, less stroke down the future. So now you are a different person because of your history. Absolutely makes sense to be on a statin to prevent stroke if you've had a history of stroke or a TIA.
But statins mess with your liver.
So statins do not mess with your liver. We've now studied that completely. There are very few patients that will have hepatotoxicity. It can affect the functioning of the liver. It can affect the numbers, but it's very unlikely to cause hepatotoxicity, which is liver toxicity. The big one is the muscle aches, which are more common as you age. That's called statin-induced myopathy. So we do take statin. Any medication can cause a side effect. That's why you just can't just walk in and get it. You have to be monitored with a doctor. Okay, and to round out the last 8, just so that we have the 8 essentials completed, obviously managing your blood sugars is important. Managing your blood pressure is very important, and then not smoking. So those are the ones that are kind of most of us know about that. So that's it. I know I gave you a wealth of information. We ran through a lot of things. But anybody have any questions, concerns, we can absolutely address now.
Is the heart problems could be hereditary?
Yes. Yes. So family history is a big component of heart disease. After the age of 75, most of the family history heart disease is already known to us. Family history, genetic reasons for heart disease would present earlier. Usually after the age in senior heart care, it's usually acquired disease, meaning that environmental, lifestyle, and then maybe some consequences of your genetics, but late sequela of it. So most of that family history probably has evened out by now. Go ahead.
I just wanted to quickly let everyone know, my name is John Frank. I'm with a group called Mended Hearts. We're a support group for heart patients. We work at Elderwerks Hospital, if you guys know. And there's a chapter here in Barrington as well. But we are heart patients, talking to other heart patients. We have monthly meetings like this. And we go through all 4 of those quadrants. So we bring in doctors, we bring in exercise specialists, nutritionists. We just had a meeting with a chef who has 8 stents in his body, and he's still going. He's changed how he eats and how he cooks. He told us how to eat healthy. And we bring in psychologists to talk about depression. I've had 2 stents. I have AFib. I have family history of heart disease. My first heart attack at 59. I'm 71 now. But I feel like depression is the biggest issue heart patients face. Because one day you're feeling fine, and the next you're in the hospital, and you're seeing yourself from the inside out on the monitor. And it's a shock, so we deal with that too. So if you want more information, you get a card from me after, but also our website is called North Suburban Mended Hearts. And there's a Barrington chapter that mentioned that visit with that.
Fantastic. Yes, that is very, very, very needed. Mended Hearts. North Suburban Mended Hearts.
Do you ever get off the statin?
Oh, yes. Yes.
Because your cholesterol numbers are okay?
No, because if your cholesterol numbers improved on the statin, well, that's why you need the statin. Again, it's all about discussing where you are in your phase of your health when I have that discussion about the coming off the statin. Are you having any side effects to it? Are there other now medical conditions that are making your cholesterol come down, maybe? So there's a lot of discussion, but yes, I have taken people off statins for certain reasons. So that's another one. Okay, there's a lot of things that are spoken about statins that are not true. Statins actually decrease dementia. So we know that. We see that in our trials, that there's less dementia with patients that are on statins. There are, though, people who absolutely claim that when they are on the statin, they get a brain fog. And I feel very strongly that every person's thoughts about their medications have to be heard and listened to and addressed. So clearly, if you start a medication like a statin and you feel that you can't function as well, we're not going to go on with that medication, or we're going to investigate what's going on. Is there something else going on? But it should not be the statins. In trials, we do not see that statins cause memory issues.
Are you accepting new patients?
I do, and I have wonderful colleagues that do as well, because I'm not by myself. We have tons of colleagues that work together. So absolutely, if you're in need of cardiac care, come find me and we'll put you where you need to be.
There's like a business card on the table.
Yes, so we've got the business cards there. Absolutely. Yes.
Can AFib be reversed?
AFib can reversed. It's hard to know what that term means. Can we get rid of it permanently? In certain cases, yes. In certain cases, yes. We are able to terminate it so that it doesn't recur.
You can terminate it. I mean, it wouldn't go away on its own.
It can if you have a risk factor. So, for example,